Hello, I'm Lillian Montoya, President and CEO of CHRISTUS St. Vincent. Thank you for joining us today for this very important community lecture. At CHRISTUS St. Vincent, we're passionate about sharing information that will help you make informed decisions about your care. The presentations you're about to watch today are an extension of our enduring commitment to improving the health and well-being of our community. The holiday season is now upon us, and on behalf of our 2,200 associates who dedicate their days to caring for our community, we ask you to please be safe. Use caution when leaving your home. Limiting the size of family gatherings, wearing masks, washing hands, and social distancing are critical measures that we all must take to save lives and keep our New Mexico hospitals from becoming overwhelmed. We're all in this together. From all of us at CHRISTUS St. Vincent, we wish you a blessed and joyful Thanksgiving. Be safe, be well, and take care of you.
Hello, I'm Dr. Lance Wilson, President of the CHRISTUS St. Vincent Clinician Group. Thank you for joining us today to learn about the important issues of prostate health. Whether you're watching for yourself or because you care about the health of someone you love, you'll be sure to walk away informed and ready to discuss prostate health with your provider, friends, or loved ones. I just want to share with you all that this is really important to me because my dad passed away from metastatic prostate cancer. I'm pleased to introduce two incredible physicians with years of accumulated knowledge and experience on this topic. Dr. Eric Anderson, board-certified urologist with CHRISTUS St. Vincent Urology Associates, and Dr. Matthew Jackson, radiation oncologist with the CHRISTUS St. Vincent Regional Cancer Center. Through the years, these expert physicians have cared for many Santa Fe and northern New Mexico patients with a wide variety of prostate concerns. Dr. Anderson will speak with you today about what the prostate is, how a healthy prostate functions, and diseases of the prostate. And Dr. Jackson will discuss prostate cancer, diagnosis, and available treatment options. I hope you enjoy the presentation.
Hi, I'm Dr. Eric Anderson. I'm the Chief of Urology at CHRISTUS St. Vincent Regional Medical Center, and I appreciate you coming and listening to this presentation today. Today we're going to talk about prostate health, and prostate cancer screening. We have 4 providers at CHRISTUS St. Vincent Urology Services. Urology is a surgical subspecialty that deals with any type of surgery involving the genitourinary tract. What is the prostate and why do we care about it? All men have a prostate, and its main purpose is to make nutrients for the sperm to aid in reproduction. Once men are done having children, it really does not serve a functional purpose whatsoever, and oftentimes leads to problems, whether that be difficulty urinating or it's the second leading cause of cancer, death in men. We're going to start off by talking just about enlargement of the prostate. Just because men have an enlarged prostate does not mean that they're going to have any difficulties from it. It's very common, as most of you guys know, and common symptoms are going to be a weakened stream, hesitancy with urination, some dribbling at the end, stop and start flow, getting up at night to urinate, a little more urgency and frequency to urinate. Some of those symptoms can be directly related to the prostate, others are related to the bladder. The severity of the symptoms does not necessarily relate to how big the prostate is. The prostate surrounds your urethra like this, and so as it gets bigger, it crimps off the urethra and makes it more difficult to urinate. So some men can have a very large prostate but minimal growth in towards the urethra and have minimal difficulties, and other guys can have a very small prostate but a lot of growth in towards the urethra and causes problems. This is the anatomy of the prostate. So where it sits is right on top of the rectum. It sits right below the bladder, and the first part of the urethra or urinary channel runs right through the prostate. The problem with the prostate is it sits in a bad place to where the muscle that keeps you from wetting your pants, your urinary sphincter, sits only a few millimeters away from the tip of it, and the nerves that allow you to have an erection run right along the outside of it. So that's why a lot of men are worried about surgery on their prostate and also medical therapies, because it can affect other parts of your life. Here we have a picture that basically demonstrates what a normal prostate would look like. In the middle, it would be just benign enlargement of the prostate. So you can see it starts to crimp the urethra and make it more difficult to urinate, just like a plug in a pipe. And then the last picture shows what cancer would look like, where there's an actual tumor or nodule in there. And sometimes that's something we can feel, sometimes it's not. When men come in to be evaluated, the things we do is obviously take a history and physical, and we assess the severity of the symptoms. And we have a symptom score that we'll ask men to participate in. And then we'll usually use an ultrasound to check to see how well men empty the bladder. A lot of times men don't empty the bladder well, but have adjusted their lives to it and think that they're emptying fine. And sometimes it could be a dangerous amount where it can cause problems with the kidneys. And then periodically we'll get PSAs if the man has at least a 10 to 15 year life expectancy, and we'll talk a little bit more about that in just a minute. When men do come in and they're having difficulties with urination, some conservative measures that they can take are: one, you want to avoid dietary irritants that can cause more urgency and frequency. So that's going to be things like coffee, tea, sodas, artificial sweeteners. And getting up at night to urinate is one of the more frequent complaints that we hear actually from both men and women. And there are a lot of components that go into that. Some of them involve the prostate, some don't. But one of the things that does happen as men and women age, their kidneys don't concentrate urine as well. And so you actually make a larger percentage of your urine at night. So that's why when you're 20 years old, you can drink a 6-pack of beer or soda right before you go to bed and sleep for 12 hours. And now if you were to do that, you'd be up every 30 minutes. Well, that's not because of the prostate. That's because you're making a large amount of urine because you don't concentrate as well. The main thing that you can do for that is make sure you're staying well hydrated, primarily with water during the day. And then you really want to limit your fluids for about 3 to 4 hours before you go to bed. And certainly you're going to pay a price for it if you drink alcohol, wine, tea at night. Other things that can affect kind of obstructive urinary symptoms where it makes it much more difficult to urinate is you want to avoid decongestant medications. So anything like Sudafed or any of the allergy medicines that have a D attached to it, so like Zyrtec D, Allegra D. Those medications make the prostate contract and make the bladder neck more narrow and make it much more difficult to urinate. Excessive alcohol intake can make it much more difficult to urinate. And then another common time that a man will get pushed over to the edge and not be able to urinate is after he's been on a prolonged airplane trip or car ride without getting up to urinate very frequently. And then they'll end up having to go to the emergency room in whatever location they've arrived in. So when you do travel, you want to make sure you get up and actually use the restroom rather than letting your bladder get overdistended. There are certain foods that also act as bladder irritants. So that's going to be like some people are very sensitive to spicy and acidic foods. So especially if you have a day that's worse than others or a night that's worse than others with urgency and frequency, oftentimes that's going to relate to something you had to eat. Sometimes it's going to also relate to cold weather, makes it more likely to have some urgency and frequency, and also anxiety does. Some people also need to take medications for high blood pressure, and those can be diuretic medications, which make them make more urine. You always want to talk to your primary care doctor or your cardiologist that prescribes those, and if you're able to, you want to usually take those in the morning rather than at night to reduce the number of times you have to get up at night. Next line from kind of conservative to more aggressive is going to be something called phytotherapy. Phytotherapy is basically plant-based treatments. So I don't have an issue with people using these. The American Urologic Association recommends against it. There's nothing dangerous about taking it, but we do not have any studies that show a significant advantage to men who take things like saw palmetto or selenium or zinc or the beta sterol. So those kind of TV commercials you see at night, the infomercials, those are basically selling super beta prostate, et cetera. Those are things that we don't really have any proof that they help, but I certainly have patients who anecdotally think that they do help them. And they're not going to hurt you, and I have no issue with you if you do take them. I think we should be supportive of men trying to be proactive about their health. One of the mainstays of treatment for BPH and its symptoms are going to be medications called alpha blockers. The most common one is going to be Flomax or Tamsulosin, but there are other brands. And basically what these medications do is they relax the smooth muscle of the prostate. So again, the prostate surrounds the urethra like this, and so the medication will relax it to make it slightly easier to urinate. And I would say most men from a medical therapy standpoint will get the most bang for their buck with this type of medication. So it's generally a once-a-day medication, and common side effects can be something called retrograde ejaculation, which is basically where when you have an ejaculation, it doesn't come out forward, it goes backwards into the bladder. It's kind of apparently a weird sensation. It's not dangerous to you, but disturbs some men who don't want to take the medication because of that. The only real side effect men can have where we don't want them to take the medication anymore is if it makes them dizzy. because it can lower the blood pressure by dilating the veins. You get your maximum benefit from it after being on it for somewhere between 1 and 3 months. Then there's a different class of medication called 5-alpha reductase inhibitors. So trade names for that are going to be Proscar, Avodart, or the generic names are going to be dutasteride or finasteride. And those are also once-a-day medications, and these are medications that actually shrink the prostate. These are long-term medications, so they take about 6 to 9 months to do much of anything. And what they'll do is they'll reduce the overall size of the prostate, usually by about 20%, and then keep it from getting larger. So the main time we'll entertain using these are in men that actually do have a fairly large prostate. It's not that beneficial in men that have smaller prostates but more symptoms. The main thing that men worry about with this type of medication is about 5 to 10% of men can get some erectile difficulties. In its smaller dosage, it's also the medication used to treat male pattern hair loss. So the straight name is Propecia, so men do like the benefit of it. You have to watch the PSA levels. So again, PSA is going to be something we'll talk about in just a minute. PSA is a screening tool for prostate cancer, and both the medication finasteride and dutasteride will reduce the PSA levels by about 50%. So you just have to make sure if you're on that medication and your primary care doctor is giving it to you that they multiply your PSA by 2 to know what the actual number is. Next is Cialis, which is primarily a medication used for erectile dysfunction, but in its smaller daily dosage, it has been found to be beneficial for improving both obstructive and irritative urinary symptoms. It can be taken with basically either of the other 2 classes of medications, whether it be the alpha blockers or the 5-alpha reductase inhibitors. The main problem with this is almost no insurance will cover this, so most men who take it will need to pay cash for it. It has become generic, so it's become much more affordable. So that's always a reasonable thing to take, and then it also is beneficial with erectile difficulties. One of the symptoms that can be related to the prostate is overactive bladder. When talking to a patient about their symptoms, you break them down into really 2 broad categories. There are going to be obstructive symptoms, which are like a weak stream, having a hard time getting started, stop and start flow, and then what goes along with that is not emptying the bladder well, which again is what we check with an ultrasound. Irritative symptoms are urgency, frequency, sometimes not making it to the bathroom in time because it's so urgent, and also getting up at night to urinate. Again, sometimes those can be related to the prostate, sometimes they're totally independent. With the overactive bladder symptoms, that's really where you want to modify your diet by avoiding things like coffee and tea, which are going to be bladder irritants. There are specific medications that we use for overactive bladder that calm it down and make it easier to store more urine. We have to be a little cautious in using those medications in men that have an enlarged prostate, because if they're already having a difficult time emptying their bladder and then they take a medication that relaxes it, it can cause them to empty even worse, and worst case scenario where they can't urinate at all. So generally prior to starting a medication specifically for overactive bladder, we always want to make sure that the man is emptying his bladder fairly well. Beyond medication and conservative measures such as dietary modification and behavioral modification such as limiting fluids prior to bedtime, we then get into procedures and surgeries. So there are a vast array of what we would call minimally invasive procedures. These can be things that are done in the office. Common things are going to be transurethral microwave thermotherapy or Resume. And basically these are procedures that can be done in the office without general anesthetic. And the basic premise of them is using some energy form to create a larger channel within the urethra. The upside to those procedures is that they can be done in the office and not require general anesthesia. The downside to them is they're very uncomfortable, and they don't last as long. So just like with anything else in life, the things that are more difficult and take more time and carry with them more risk are going to work much better than the things that are easier to do. One of the procedures that's caught on in recent years is something called a Eurolift. And that, in most cases, is something done under anesthesia, but some urologists are doing it in the office with some sedation. The basic premise of it is you look inside the urethra through the penis and into the prostate, and then you deploy these springs that pop open the urethra. So far, it looks fairly promising. You have to be a little bit more selective in terms of the patient that has this done. Again, on the spectrum, this doesn't work quite as well as surgical options that we'll talk about in just a second, but certainly better than medication for most men. Laser procedures are probably the most commonly performed procedures for reducing the size of the prostate and improving urinary symptoms. And the basic premise of those is going in through the urethra with a camera and then using a laser fiber and under direct vision, vaporizing the tissue of the prostate to create a larger channel. The overall size of the prostate will remain the same, but it is creating a much larger channel, kind of like coring out an apple. And those are very successful surgeries. The majority of men will notice a significant improvement in their stream, reduction in hesitancy, and improved emptying, which will then oftentimes lead to reduction in the times of going to the bathroom. The reason we do laser procedures much more commonly than the gold standard, which is the transurethral resection of the prostate, which is what was really only available for several years until lasers became available, is that the lasers allow us to do this as an outpatient, and the patient doesn't have to be hospitalized for a few days, and there's significantly less bleeding, and that will lead to fewer complications. So in the majority of cases, these procedures will take about an hour, and then the patient will go home with a catheter for a few days, and they will see almost immediate improvement in terms of their urination once the catheter comes out. The restrictions are that men can't do any heavy physical activity for about 2 weeks and no sexual activity for about a month. The main downside to these types of procedures are that almost all men will have some degree of, again, the retrograde ejaculation, which, again, is not hazardous to men's health, but certainly bothers some men not to see their ejaculate anymore. It would only be a health issue if one was still planning on having children, which most men in this age range are not. The gold standard remains transurethral resection of the prostate, and that's basically where you go in through the urethra, and instead of using a laser to vaporize the tissue, you use a cutting loop like this to slice through the prostate to create a much larger channel. Nothing works as well as it, but it does cause more bleeding and usually requires a couple of day hospitalization. Occasionally will require a blood transfusion, but that's rare. For men that have really large prostates, so in the 99th percentile, their prostates are too large to do the procedures that we just discussed. You can only reduce the prostate so much by going in through the urethra. So it's a much more involved surgery where you have to do something called a simple prostatectomy, which is really not very simple. And that involves abdominal surgery where you open up the abdomen, open up the bladder, and then core out the prostate that way. And the majority of these nowadays can be done robotically, which is still a very big operation, but a little bit easier to heal from, and that's certainly available here. So now we're going to talk a little bit about prostate cancer screening. Why is this important? Prostate cancer is the most common cancer in men and the second leading cause of cancer death in men after lung cancer. So our general recommendations are if one has a family history of prostate cancer, then we'll usually start screening at age 40, whereas if they do not, we'll usually start screening at age 50 to 55. There are two components to screening for prostate cancer. One is going to be the PSA blood test, and the other is a digital rectal exam. The reason they're both important is because the PSA isn't always a reliable indicator of prostate cancer, and about 30% of men, when we feel the prostate and if there's a nodule, they will end up having prostate cancer. So they're both fairly important components of screening for prostate cancer. There's some controversy regarding prostate cancer screening because the recommendations have changed back and forth over the past 15 years. It used to be that we screened all men for prostate cancer regardless of age. And then some large studies came up saying that we really weren't doing the majority of men over the age of 75 much of a service by continuing to screen for prostate cancer. And the reason is that most men age 75 have a life expectancy of 10 to 15 years. And in the majority of prostate cancers, they're going to be slow growing and non-aggressive. And studies indicate that those men are not going to benefit from treatment for the prostate cancer. There are certainly going to be exceptions to that, but that needs to be a discussion that's held between either the primary care physician and the patient or the urologist and the patient, and it needs to be the patient's decision, not the physician's decision. So PSA was approved for screening purposes in 1994 and really revolutionized how we screen and treat prostate cancer. The number of people diagnosed went up significantly because prior to that, we were only able to diagnose people after a biopsy, which was performed based on finding an abnormality on the rectal exam. The vast majority of prostate cancers since the advent of the PSA are found because the PSA is high rather than finding something on digital rectal exam. This has led to the most prostate cancers being found at a much earlier stage than prior to the PSA. What that has done is it's reduced the mortality, which is the death rate from prostate cancer, by about 40% since the PSA came out. So the current guidelines, again, are if someone has risk factors for prostate cancer, which will be a primary relative who has it, that means a father or brother, that increases your risk by about 3.5 times over someone that doesn't have a family history. They need to start being screened at age 40. Otherwise, really between the ages of 50 and 55. We try to avoid screening for prostate cancer in men over the age of 70 to 75. Again, that needs to be an individual's decision, not someone making it for you. But there are certainly downsides to screening for prostate cancer after that age. There can be some psychological difficulties of telling someone they have prostate cancer and then saying we're not going to do anything about it because you're going to be fine. So I would really encourage you to really think about whether that's something you want to be screened for after that age. The PSA is not a perfect test. It can be elevated because of prostate cancer. It can also be elevated because of benign enlargement of the prostate. So the more prostate cells that you have, the higher the PSA. It can be elevated because of inflammation. So inflammation can be from riding a bicycle, from riding a horse, just from everyday activity. So when you do a PSA, you want to avoid sexual activity for a few days prior and certainly any vigorous exercise for a few days to get a more accurate reading of the PSA. There are going to be age-adjusted PSAs, which is also important. So the upper limits of PSA in terms of normal are going to be 4 nanograms per milliliter. And that only holds true through the ages of 60 to 69. After the age of 69, the upper limits of normal are up to 6.5. So you just want to make sure that if you're 72 and your PSA is 4.2, you realize that that's a normal PSA. We do take into account the velocity or rate of change, so certainly there's some concern if someone's PSA goes from 2 to 3.5 over the course of the year, and we may follow that a little bit more closely even though the PSA is still normal. There's also this thing called PSA density, and that relates again to how large the prostate is. So again, if we have a man that has a very large prostate and their PSA is elevated, we want to compare the ratio between the size of the prostate and the blood test, the PSA, and adjust for that. If you do have an abnormal PSA, what are the steps that you can take? There are some additional blood tests and urine tests that you can do, such as a PCA3, 4K score, and what those do is they give you a statistical probability of having a clinically significant prostate cancer. They are not definitive. They do not replace a biopsy, which is the only way to know whether you have prostate cancer, but they can be additive in terms of making an informed decision. We very commonly will use MRI in the modern era. And MRI is fairly good at finding lesions that look more worrisome for higher risk prostate cancer. It doesn't necessarily do a great job of differentiating between lower risk prostate cancers and things like inflammation, but it's certainly become an important part of prostate cancer, both in terms of treatment and screening. And ultimately, prostate biopsy, again, is the only way to know whether one has prostate cancer. And that's an office-based procedure. It's mildly uncomfortable for sure. And it involves placing an ultrasound probe in the rectum and allowing us to visualize the prostate. We inject some numbing medication And then we'll usually take 12 biopsies with a little needle gun. And the whole process takes about 5 minutes from start to finish. The vast majority of men say that it wasn't nearly as bad as they were thinking it was going to be. There are some minor risks, including bleeding and infection. The rate of infection has been reduced significantly by doing cultures prior to doing the biopsy. So it's very rare in the modern era that we have to hospitalize patients for an infection. Why is this an important issue? Approximately 1 in 6 men will be diagnosed with prostate cancer over their lifetime. It remains the second leading cause of cancer death. And at this point, we really don't know why men are at increased risk from it other than genetics, and there doesn't seem to be any method to really prevent it. There are some theories that maybe smoking cessation will reduce the risk of getting a higher risk prostate cancer. It certainly doesn't decrease the risk of getting prostate cancer. It seems like a low animal fat diet may play a role. An interesting thing is that in Japan, for example, the rate of prostate cancer is fairly low, and then within 1 generation of a Japanese American person living in the United States, their risk is the same as anyone else that lives here. There really aren't any dietary supplements that are specific to the prostate to improve its health. A lot of men take zinc, selenium, pomegranate, pumpkin seed. And again, there's nothing wrong with doing that. It probably improves your overall health and immune system, but there is no study that shows that there's a significant advantage to using them. The primary risk factors for prostate cancer are primarily genetic. If one has a primary relative, whether that be a brother or a father that has prostate cancer, their relative risk of developing prostate cancer is about 3.5 times higher than someone who does not have a family history. The other things that play a role are African American men are not necessarily at increased risk of developing prostate cancer, but unfortunately at higher risk of developing a much more aggressive prostate cancer. So they are men that will usually recommend screening at a younger age and having a lower threshold for performing a biopsy. Certainly the rate of prostate cancer will increase with age. So the average age of diagnosis is 66. But we certainly diagnose younger men in their early 50s, and we will periodically diagnose men in their 80s. The good news is that the vast majority of men, if they were to be diagnosed with prostate cancer, are going to do very well. The overall 5-year survival rate is greater than 98%. So in most cases, it's not something to panic about if you are diagnosed. Thank you very much for joining us for this discussion. I know Dr. Jackson will be talking to you now about potential treatment options for prostate cancer.
Well, hey everyone, thanks for tuning in. My name is Matt Jackson. I'm a radiation oncology physician at the CHRISTUS St. Vincent Regional Cancer Center right here in Santa Fe. My job is to talk to you a little bit more about prostate cancer specifically, especially because that's a lot of what I deal with on a day-to-day basis. So it's kind of a whirlwind tour. So buckle up, and I'll take you through several different aspects of prostate cancer treatment and hopefully not confuse you along the way. On this first slide, I hope to convince you why prostate cancer really matters in this country and why you should be concerned about it and why it might matter to someone in your family. So you'll see here we have statistics from the American Cancer Society, and these are put out every year estimating the incidence of each type of cancer in the United States, as well as the deaths from that type of cancer. Now, this chart, commonly everywhere you see it, will often exclude kind of little, almost not totally insignificant, but things we don't worry so much about, like basal cell skin cancers on your ear or a little squamous cell carcinoma on your scalp. But in terms of like real deal cancers that require serious treatment or consideration, this is sort of a chart for that. And so you'll see that of the estimated new cases in this country, you'll see that prostate cancer is the most common new diagnosis of cancer among men, whereas the corresponding for women, that'd be breast cancer. There are estimated at least to be about 200,000 cases of prostate cancer this year in this country alone. Now going down to deaths from cancer. Thankfully, prostate cancer is not the most lethal cancer in men. It doesn't kill the most, but it does kill the second most, right after lung cancer. So this is something that we take serious. Not every prostate cancer is something that needs to be treated or something that is going to kill someone, and we'll talk a lot about that today. But there are plenty of serious prostate cancers out there that need attention, and a lot of them that we need to treat. The single most important thing for you to remember in our lecture today is that prostate cancer represents a vast spectrum of disease. So not all prostate cancers are created equal. Just like the color purple is not the color orange, one prostate cancer might be something that never even needed to be diagnosed, quite honestly, or if it was diagnosed, we can just watch. Whereas there's other prostate cancers where we really need to batten down the hatches, start treatment immediately, or that prostate cancer is really going to cause trouble or even threaten that patient's life. So as we move through this talk, remember, although we're titling this talk Prostate Cancer in General, really what I'm talking about at a molecular level is a vast array of a bunch of different diseases that we kind of lump under one roof. That's a little confusing, right? You're probably scratching your head wondering, well, how do we go from here? If prostate cancer is so different, one case to another, how do we sort it out? And how do we move through things systematically? This seems sort of overwhelming. And so we need a roadmap. And so just like Homer Simpson had that roadmap, here's our roadmap for this talk today. This is what I'm going to take you through step by step and explain things along the way. Let's start simple and start at the top with screening. Who should be screened for prostate cancer and how do we screen for it? Well, mostly what we're talking about when we talk about screening for prostate cancer is a simple lab draw, a simple blood test that can be done in any lab all across the country. And that's the PSA. What that stands for is prostate-specific antigen. Now, PSA is not just a marker of prostate cancer. Normal prostates secrete PSA all the time. It's a normal protein that your prostate ekes out, hopefully in small amounts, into your bloodstream. But you can get more PSA protein leaking out into the bloodstream in various conditions, like not just prostate cancer, but benign prostatic hypertrophy, which is where the prostate grows as a gentleman ages, prostatitis, which is inflammation or an infection of the prostate, even trauma or an injury to the gland itself can increase PSA. So you have to keep those things in mind. And this lab test, while it can sort of be the smoke, it doesn't actually show us the fire. And we need to take further steps to investigate a little bit more. In addition to screening with PSA, another thing that we'll often use is a digital rectal exam, often referred to as a DRE. I can tell you that's your least favorite part of your doctor's visit, and it's my least favorite part of your visit too. But a lot of times these things are important, although not nearly as important, it turns out, for screening as PSA. I'm sure all of you would rather have a simple lab draw than a DRE, and thankfully the evidence backs that up. Using a digital rectal exam on its own turns out is only about 4 to 21% sensitive in the detection of prostate cancer. So it's something that we can utilize maybe annually in combination with PSA, but not something that we're going to want to use to replace a PSA test. Now, screening for prostate cancer in general is a point of mild controversy. There are certain very thoughtful, very smart people who are not wrong, who say that we're over-screening for prostate cancer. And the U.S. Preventative Services Task Force, which is kind of this big government body that makes recommendations on which cancers to look for, which cancers to screen for, really kind of set the world on its ear in 2014 when they came out and said, stop screening for prostate cancer. You're diagnosing way too many cancers that don't need to be treated. These are indolent diseases, a lot of them, and you should just wait until a guy's diagnosed, maybe he's having symptoms or some other things bring him to medical attention. However, since then the data was really conflicting and more and more data came out that there actually is a role for prostate cancer screening if you do it carefully and selectively, and importantly, after you screen and detect a prostate cancer, be willing to just watch it or take necessary steps not to jump into action too quickly. And that's important and something we'll talk about later. Some data even showed that since 2014, and that recommendation came out, more gentlemen across the country were presenting with prostate cancer that had already spread to their bones, and the incidence of prostate cancer-specific mortality, or the number of guys dying just because of prostate cancer, rose slightly in this country. That's a bit of a controversial point, and not every study showed that, but in general, the data were telling us that there was a way to screen for prostate cancer and a way to do it correctly. So a few years later, the U.S. Preventative Services Task Force came back and kind of reversed itself a little bit and said, actually, you can screen, but it should be a thoughtful discussion between a patient and their primary care provider about the risks and benefits of screening, and don't screen a guy who doesn't know he's being screened or at least doesn't want to be screened. It should be a more thoughtful consideration, maybe not just carte blanche where we're drawing everybody's PSA every time they go for a lab draw. At the end, if you're deciding whether or not you should be screened, it's up to your own individual preferences and value systems. Are you someone who likes more information, or are you someone who likes less information? Those are all things to think about when you talk to your doctor about whether or not you want to be screened for prostate cancer. So here's a slide. It's a little bit busy, but it's from our National Comprehensive Cancer Network, which it's abbreviated NCCN, and essentially is a panel of multiple institutions across the country. All the big tertiary academic medical facilities send a few experts to put on these expert panels and basically issue a rule book or a playbook of how we should be diagnosing and treating cancer. You'll see that the NCCN tells us that at about age 45, we should start thinking about screening for prostate cancer. Age 40, if you're Black, because we know in Black men, prostate cancer often presents earlier in life and is more aggressive when it does present. So we risk stratify a little bit and start screening those gentlemen earlier. And for early detection evaluation, here's what you're looking for when you draw a PSA. So if you're 45 to 75 years old, you have your PSA drawn and it's less than 1, your DRE is normal, well, great. You don't need another PSA drawn for at least 2, maybe even 4 years. If your PSA is in between 1 and 3, and that's nanograms per milliliter, then it's still fine. We don't need to biopsy you. We don't need to do anything. That's a perfectly normal PSA. Maybe it's a little higher, so let's check your PSA again next year or maybe 2 years from now, a little shorter frequency. And then if your PSA is over 3, or if you're 75, so you're older and you want to be screened, and it's greater than 4, those are guys who probably should go talk to urology and at least consider a biopsy. Now, I think a biopsy is not a foregone conclusion as soon as your PSA hits 3. Dr. Anderson and Dr. Shaw, both of our urologists here, are absolutely phenomenal at walking you through this in a stepwise way, taking a thorough medical history, seeing what other reasons you might have for having an elevated PSA. I promise you these guys are not just going to jump straight to a biopsy, but rather talk you through the options and see if it might make sense for them to do a biopsy and see what's going on. So what is a prostate biopsy? So here's a slide that sort of illustrates what a biopsy is. It's essentially a procedure where we're going to take several different samples from the prostate itself, from multiple different areas in a very organized way. On the left-hand side of the screen, you can see kind of the awkward, weird position you're in there, and it's a transrectal biopsy is how most of these are done. So basically an ultrasound probe is inserted into the rectum. That allows the urologist to see a detailed ultrasound picture of the prostate gland itself, and then sort of work their way through the prostate, taking 2 samples from each side at each of the 3 levels of the gland. So the top of the gland is called the base, the middle is appropriately called the mid-gland, and the apex is down at the bottom. And so in general, a urologist is going to take approximately 2 samples from the left and right base, left and right mid-gland, and left and right apex, generally giving us at least 10, but hopefully 12 samples of prostate tissue to deal with. We send that to the lab where a pathologist looks at those slides under the microscope and sees if we're dealing with prostate cancer. This is what the pathologist will tell us if there's cancer. They'll talk to us about the Gleason Score. And the Gleason Score is named after Dr. Gleason, a famous pathologist who founded this system and described prostate cancer in this way. And this is probably the single most important prognostic piece of information when it comes to dealing with and deciding how aggressive your prostate cancer is. So when you get your pathology report back, if you have prostate cancer, it's going to look like an elementary math home worksheet. There's going to be a bunch of simple addition on it. You're going to see one number plus another equals a total. For example, 4 plus 3 equals 7. What that means is the pathologist is always going to tell us the major pattern, which is the most common type of abnormality they see, that being a Gleason grade 4. And then they're going to tell us the second most common that they see. And that, in my example, might be a 3, but it could be anywhere, honestly, from 1 to 5. And they add those 2 numbers up. Here equals 7, and that gives us a score for how aggressive or how sinister, how nasty your prostate cancer looks underneath the microscope. Essentially, Gleason score going from 1, which looks just like normal prostate cancer cells, goes all the way down to 5, which looks sort of quite deranged, quite mutated, and might act kind of aggressively. And this gives us a sense of what we need to do about your prostate cancer and how soon. We realized, though, just in the past few years, that there was actually a big problem with how we as the medical community and as physicians graded prostate cancer with a Gleason score, starting pretty much at 6 and going up rarely to 10. A lot of patients, we realized this motivated them to pursue over-treatment. For example, when you start a scale at 6, that can seem quite alarming. A lot of people out there are used to hearing about cancer in stages. And keep in mind, I'm talking right now about grading, which is something that's totally different. But nevertheless, the whole 1 through 4 stages of cancer have worked their way into sort of the American lexicon and the American mindset. And so you can imagine how alarmed a lot of guys are when you come in. Maybe they have a Gleason 6 prostate cancer, which honestly, a lot of those don't even need to be treated. We can just watch them. But they think, oh my goodness, I have a stage 6 prostate cancer. This has to be treated now. And they're really worried and they're scared and they're apt to not make rational decisions. So in 2014, the World Health Organization said, whoa, we need to pump the brakes, take a step back, and sort of reorganize these better so patients can understand them. So now we call Gleason grade 6 is actually in grade group number 1, and that's low-risk prostate cancer. Intermediate category would be anything that equals 7, so that's 3 plus 4, 4 plus 3. And those are grade groups 2 and 3, because as it turns out, it actually does matter what's the major pattern and what's the minor pattern. So if your major pattern is 4, as a whole, that group of guys might have slightly worse outcomes than 3 plus 4, although overall, outcomes are still phenomenal for guys in the intermediate risk category. And then folks that start to have Gleason scores you're starting to see a number 5 pop up, or 4 plus 4, basically scores of 8, 9, or 10. Those are more aggressive prostate cancers. We use not just Gleason score, but a couple of other features, basically to put prostate cancer patients into boxes that we can think about in a conceptual way and more accurately and easily relay information and treatment options to patients. There's 3 main things that we want to think about. And of course, there's a lot more than that. I'm oversimplifying a little bit for the purposes of this lecture, but basically, this is the way to think about it. In your low-risk category, you're going to have a tumor stage that is basically not palpable at all on digital rectal exam, or if it is, it's a tiny little nubbin in 1 little quarter of the prostate. The PSA is less than 10, and the Gleason score is a 3 plus 3 equals 6. Those are all low-risk prostate cancers. In that intermediate risk category, that's starting to get into those tumors that we can feel quite easily. Maybe those are encompassing the entirety of half of the prostate gland and even starting to cross midline into the other side on a digital rectal exam. The PSA for an intermediate risk prostate cancer is in between 10 and 20, and the Gleason score adds up to 7. Now keep in mind that we always take your worst factor when thinking of what group you should be in. So if your tumor was not palpable and your PSA was only 6, but your Gleason score is 7, you're an intermediate risk patient. And that's how we try to frame things to help you decide how you'd like to proceed. High-risk prostate cancer is a tumor that's really quite large. It's probably erupted outside the shell of the prostate, so-called capsule, or into the seminal vesicles, which are little bunny ear-shaped glands that kind of sit up behind the prostate. Also, PSA is greater than 20, and a Gleason score of 8, 9, or 10 will also put you into this high-risk category. Let's say that a gentleman has just had a biopsy for prostate cancer. His PSA was 4, his DRE couldn't really feel anything, and Gleason score was 6. The first decision point as that patient works his way down the decision tree is to decide, hey, do I want to pursue active treatment or would I rather do active surveillance? And I would encourage that individual, if he was comfortable and it fit with his preferences, to think long and hard about active surveillance. It's a very well-validated modern approach for treatment that we're really used to here in Santa Fe. Generally, active surveillance is going to be for that guy with low-risk prostate cancer. There are some exceptions, maybe a really old individual or someone with some comorbidities that has some 3 plus 4, 4 plus 3 prostate cancer. We could also do active surveillance for that individual. And it's also important to note that active surveillance does not equal observation. That's a little bit of semantics, but observation's a little different. That's someone who really does have significant comorbidities, who has less than a 10-year life expectancy, or maybe much less than that. Someone who we're not even going to really consider treatment unless that prostate cancer really starts to spread and act up and cause problems, because we might not really be benefiting that person's quality of life and extending their lifespan by really treating that cancer. However, for most of our patients, they have a lifespan of much longer than that we would anticipate. But if you have a low-risk prostate cancer, then let's just watch it. Let's watch it carefully. It doesn't mean that we can stick our head in the sand and ignore and pretend like none of this ever happened, but it means that we need to be diligent, thoughtful, and stepwise about how we follow you. So how do we do that? Well, with some of the things we've already talked about. It means we're probably going to draw your PSA every 6 to 12 months, a repeat digital rectal exam no more frequently than once a year, and then consider a repeat biopsy usually every 18 to 24 months or so, though there's some flexibility there. But it does require repeat biopsy periodically, and that's a key part of what we have to think about when it comes to active surveillance. The other thing we need to think about when it comes to active surveillance is incorporating MRI. MRI scans are really rising to prominence in the diagnosis and management and pre-treatment evaluation of prostate cancer. This picture here you can see on your screen is a picture of a prostate MRI and shows a tiny little nubbin of prostate cancer right out on the very edge of the prostate that might have been missed by a biopsy if the MRI hadn't picked it up. Now, Dr. Anderson and Dr. Shaw are very used to using modern multiparametric MRI imaging in their clinic to guide their biopsies in a more accurate way. And I've seen this firsthand. The patients who have previously had negative biopsies, but their PSA kept rising, the patient felt like something just wasn't right. We knew there was trouble brewing. Dr. Anderson or Dr. Shaw order an MRI. They use that to guide their biopsy in a directed way, and we were able to diagnose the cancer. Thankfully, here in Santa Fe, at Santa Fe Imaging, we have a great MRI machine. It's brand new. It has a super strong, very modern and sophisticated 3 Tesla magnet, which gives us extraordinarily high-resolution prostate pictures. And importantly for the patient, is it now obviates the need for the placement of an endorectal coil while you have the MRI, so leading to a much more comfortable experience for the patient. Used to, on older MRI scanners, when a guy had a prostate MRI, had to have a coil or a plastic device placed in the rectum for the duration of the MRI, which is a bit uncomfortable, something obviously we'd like to avoid if we could. What about active surveillance? When do we initiate treatment then? Because this doesn't mean we watch it forever. We will watch it indefinitely as long as things stay quiet and stay stable. But if we notice that cancer starts to worsen, if that Gleason score moves from a 6 to a 7, that PSA starts to move well up above 10, or we're starting to feel more nodularity or more prominence on digital rectal exam, that's the time then to initiate treatment and talk about moving forward with therapy with your physicians. Pros and cons of active surveillance. Pros, I would say that over half and up to 2/3 of men will avoid treatment for their prostate cancer altogether, which is huge. And I think that number speaks volumes, and I think really gets us past that question of should we or should we not screen. I think it's much easier to really embrace screening for gentlemen who are interested now that we have well-validated active surveillance paradigms, and as long as we're not scared to move in the direction of active surveillance for appropriately selected men. Because again, if 2/3 of men on active surveillance won't need to leave that paradigm and move towards treatment, I think that's a win. That means that they avoid any possible side effects of treatment. There's no better way to avoid all possible side effects related to therapy than to not do anything at all. And that means their normal activities are less affected. They don't have to worry about any side effects, trouble with urination or bowel movements or sexual function that they might have to think hard about when it comes to the different types of therapies. Disadvantages, though, of active surveillance, it's not for everybody. Rarely, you will miss an opportunity for cure, although I will tell you that's exceedingly rare, and it doesn't seem like active surveillance impacts cure rates overall in a negative way when it comes to the population level. But sure, there probably has been a handful of gentlemen who have had their prostate cancer kind of get out of the bag in between surveillance visits. That can lead to some understandable anxiety on the part of the patient. A lot of my patients started out on active surveillance and then came back and said they wanted to do treatment because they were just too anxious. They were worried about knowing they had a technical diagnosis of cancer, even though we told them it was low risk, it was unlikely to move forward quickly. They were just losing sleep, they were anxious, it was affecting their quality of life, they just wanted to move forward with treatment. And the periodic repeat biopsy thing is kind of a non-starter for some of my patients as well. Prostate biopsy is obviously not the most comfortable thing in the world, something nobody looks forward to. Some guys would just rather do one and then treat it and never have to do another one again. Let's say that individual heard a little bit about active surveillance, thought it sounded like a great idea, but maybe wasn't for him. He decided he wanted to do active treatment. Our two very well validated, scientifically proven for years standards in this space are either surgery or radiation. And both are phenomenal treatments for prostate cancer with equivalent and very high cure rates. So even though I'm a radiation oncologist, I can tell you that I fully support surgery. I think it's a fantastic treatment option for patients. And I honestly think that it should come down to the individual and your own sort of preferences and values and how you'd like your cancer treated. Whenever you're visiting with someone talking about prostate cancer, the last thing you ever want that consultation with a physician to feel like is a sales pitch. If you ever feel like the doctor sitting across from you is really trying hard to convince you to do his or her therapy, I'd encourage you to run the other way. Ideally, what you want is sort of a team-based approach where people are presenting things in an even-handed way, hopefully presenting you with the relevant data and scientific evidence, and then empowering you as the patient to make your own decision. I meet with a lot of patients who have prostate cancer, and we meet and we explain everything, and they ultimately will call me back 2 weeks after our consultation. They'll tell me they're going to go for surgery. I congratulate that individual. I think that's something I fully support and I feel really good about as long as they're moving forward, as long as they're cancer-free 5, 10, 15 years from now. I don't care if I'm the one to do it or not, as long as we get them there. So let's talk a little bit about surgery first. The surgery for prostate cancer is called a radical prostatectomy. And it's basically sort of an en bloc removal of the entirety of the gland, and then those little seminal vesicles that I told you about, kind of sticking up behind the gland. So in this picture, you'll see sort of a sideways view through a guy's pelvis. You can see a dotted dashed line around the area that's sort of removed. And on the right side of the screen, you can see the incisions that are sort of made on the low abdomen to access that area. There are a couple of different ways to go about this. There is an approach to remove the prostate gland sort of through what's called the perineum, or some guys call it the zipper, the area between their scrotum and the anus. That's kind of fallen out of favor because it's not so easy to kind of visualize the nerve bundles on the side of the prostate that we want to try to preserve if we can, to preserve erectile function after the prostate's removed. So most prostatectomies in this country now are kind of done coming in from above, the so-called retropubic approach. Retropubic meaning coming in behind the pubic bone in the low abdomen. And so you can either do that open, kind of like a traditional surgery, and that incision you see there on the left, and then on the right, those multiple small dots might be the port sites that you would see for a more minimally invasive approach, like a laparoscopic prostatectomy or even a robotic assisted prostatectomy. People have sliced and diced this several different ways, and it's a sort of a point of, I would say, some mild controversy, but overall it doesn't really look like there's a difference in cure rates between the different radical retropubic approaches. One can quibble about whether one might lead to a slightly shorter hospital stay or less blood loss, but overall, in the hand of an experienced, quality surgeon, all of these approaches are going to be very effective at curing the prostate cancer. Here in this picture, you kind of see a before and after. So that prostate is there in the top with the seminal vesicle. That comes out, and then the urologist is basically going to reattach the urethra, which is the tube that carries urine from the bladder out through the genitals. They're going to reanastomose or reattach that, and then a catheter or a Foley catheter is going to be placed into the bladder for a few weeks while that area kind of heals and that tube heals up so it can transport urine on its own again. So that's a little bit about surgery. Here's a little bit more about what I do, and that's radiation. And we can divide radiation into sort of two types. Most of the prostate cancer treated with radiation worldwide will be done with external beam radiation therapy. And so here's a little bit about that. That's delivered with this machine called a linear accelerator. And so this machine basically generates a precisely focused photon beam, which is an X-ray beam, right on the prostate gland itself with exceptional accuracy, damaging the DNA of the cancer cell so the cancer can't divide and instead it dies. So there's a lot of misconceptions out there that radiation just kind of stuns the cancer or keeps it at bay for a little while and eventually it's going to grow back if you're young enough. That's not true. It's actually totally lethal for prostate cancer, at least that's the intent, and it's very effective at doing that. This is an invisible, painless beam. It doesn't hurt going in. You're not taking any radiation home with you. Almost all of my patients drive themselves to and from every single appointment. There's no hair loss, no nausea, and they feel quite well enough to work full time. I've had patients lead high intensity exercise classes, climb Wheeler Peak, et cetera, right in the middle of radiation therapy. Treatment is typically delivered in 5 minutes or less during a 15-minute appointment time. Usually guys are in and out of my department and usually about 25 minutes door to door on their radiation days. One downside of radiation, I would say, is that it takes a while on the calendar. It takes several different treatments, and we take advantage of the body's ability to easily and quickly repair itself, whereas cancer lacks the ability to repair its DNA. And so because of that, we do something called fractionation, where we split radiation up into a bunch of very well-tolerated treatments. But that means on the calendar, it means several different appointments. Now, you probably have friends or family who were treated with radiation for prostate cancer who were there for 9 weeks for 44, 45 treatments. That's a little bit old school at this point and something that's hardly ever done. Nowadays, treatments are getting shorter and shorter. Our standard treatment course in our clinic now is about 5.5 weeks, and there are treatment courses that are even shorter for appropriately selected patients. The radiation energy comes in basically from outside of the body. Nothing ever touches you. You don't feel it. It feels like laying there and getting an x-ray, because that's exactly what it is. It's sort of a focused, precise x-ray beam. You'll see on the left-hand side of this graphic the way prostate cancer used to be treated with radiation years ago. This was something called 3D conformal radiotherapy, where maybe you had 3 or 4 really big beams kind of coming in from the sides and from the front and the back. And those basically made a square around the prostate. And that's, it was decent, that was okay. But the prostate is a circular kind of citrus-shaped organ. It's not a square. And so we want to make things tighter. We want to make things more conformal. And so we moved through the years to doing more and more sophisticated technologies that deliver ultra-precise treatments right on the gland itself. Most of our treatments now are something called VMAT or arc-based therapy, and this is where sort of that invisible beam sort of rotates and arcs around the patient in 360 degrees, coming in almost like spotlights on a stage. Picture if you went to the opera and someone came out for a solo performance and you have multiple spotlights all around the stage at the opera, trained right on that performing artist and the microphone. The whole auditorium stays dark, but you have a bright white circle of light right on that performer. It's sort of an analogous concept. So now this is what our treatment plans look like. This is a de-identified slice of a patient that was recently treated in our clinic. And you can see this is a CT scan. And in here, we've colored in the organs in the patient's pelvis, their bladder, their rectum, their penile bulb, their femoral heads. But there in green and surrounded by those tightly wrapped colored lines is the radiation dose itself. And you can see right there how close those high dose radiation lines really hug super tight and basically make the same shape as the prostate, minimizing dose to nearby surrounding organs. Another thing you want to look for, no matter where you're treated for your prostate, if you choose radiation, is that they have image guidance or image guided radiotherapy, something called IGRT. This should be standard practice now at any modern sophisticated radiation clinic. And so we have these ultra rigid robotic carbon fiber tabletops that don't flex and sag, and they can basically move in 3 directions. And our treatment machines can take a picture of the inside of your pelvis before they treat you, basically bringing you back into ultra precise alignment, because it's actually turns out to be almost impossible to lay someone down and get them in the exact same position 28 times in a row for all of their radiation treatment appointments. But we demand extreme accuracy down to the level of the millimeter, being able to see inside the pelvis, fine-tune and make little micro adjustments before each and every single fraction is delivered allows us to achieve that. Often I get asked about protons in my clinic, and so I wanted to include one brief slide on that. This is basically a graph showing something called the Bragg peak, which theoretically should make protons absolutely fantastic. The proton comes in at a low energy, moves through tissue, spikes on that Bragg peak, and deposits that energy all in kind of one big dump right in one spot. And that should lead to extreme precision and accuracy, and it does in sort of theoretical models in a computer, and then shows to be nice and tight in basically what we call in silico studies, which are kind of modeling studies where we treat tumors in mannequins with proton beams. And we can see, yep, sure enough, proton makes a nice, tight dose distribution, even tighter than traditional radiotherapy, right around the organ of interest. Well, the problem is that hasn't really been a home run for patients in the clinic. It turns out that most of the side effects derived from radiation therapy, what there are related to the high dose region and where that basically a prostate touches the bladder, kind of touches the rectum. And that's not that much different between protons and photons. And so because of that, this has been studied, and in 2 studies, there's no difference in toxicity between protons or photons. And in another 2 studies, it was kind of befuddling, but it turned out that there was actually increased toxicity with proton-based treatment as opposed to photons. So there's certainly further research and further development. It's a technology I'm excited about, and I think we'll get there. We're just really not there yet. They're not quite ready for prime time in terms of all patients really needing to travel long distances and incur the high costs associated with proton-based therapy. What about something that's also extremely conformal, really tight dose wrapped right around the prostate gland? That's a different type of radiation called brachytherapy. And that's basically where a radioactive source is implanted into the gland itself. There's a couple of different ways to do this. There's either low dose rate or high dose rate. Basically, LDR is what you hear about when you hear guys talk about the seeds or a seed implant. Basically, little radioactive seeds are deposited in a similar fashion to how the biopsy was done with a rectal ultrasound probe. This time the needle goes in through that strip of skin, but just underneath the scrotum and in front of the anus. And those seeds are deposited into the prostate gland, left there while they decay and they fade to nothing slowly with time. This is a great way to treat prostate cancer. It's very effective, but obviously a little bit more invasive than external beam radiation therapy, arguably a little less invasive maybe than a prostatectomy. For some guys, it represents a nice middle ground. One nice part about it is, much like surgery, the treatment is over in a day, and then you go home to sort of recuperate and recover. There are some more significant urinary side effects, usually, taking these patients as a whole, just because there's a little bit more swelling and inflammation in the gland itself, which looking at that picture, I think you might be able to appreciate. One of the last things I'll talk about with treatment is this idea of androgen deprivation therapy, or ADT. Basically, this is the idea of kind of knocking a guy's testosterone down temporarily for a period of time while we're treating his prostate cancer. The reason we do this is that a really smart guy years ago won a Nobel Prize in medicine for realizing that prostate cancer absolutely hates it when you take testosterone away from it. If you have a bunch of prostate cancer cells in just a tissue culture, in sort of a petri dish, and you do nothing to that lump of cancer cells except take testosterone away from it, it'll shrivel up big time. So we know that by temporarily fooling a guy's body into stopping production of testosterone, we can improve outcomes by a little bit. It doesn't change things a whole lot, but it can add us a few percentage points in terms of overall survival. So a lot of times for an unfavorable intermediate risk, or certainly for a high-risk prostate cancer, it's worth doing that and escalating the side effects of therapy to match a more aggressive cancer. So this is oftentimes called chemical castration. Is kind of one way to think about it, but it's temporary, it's reversible. So it's usually given with injections, which can be given just once every 3 or 4 months. Basically fool your central brain into shutting down your testicles, tell them to stop all testosterone production, kind of giving us an opportunity to attack the prostate cancer from multiple different angles. But there are side effects. Not having testosterone around makes you feel pretty crummy. You can feel tired, you can feel depressed and moody, you can have hot flashes, your sexual function's no good, your libido's no good. Actually can temporarily worsen things like blood glucose and your cholesterol, stuff like that. So there's quite a long list of side effects. So this is a careful decision that you have to make. Not every patient needs this at all, but sometimes it can be useful, again, especially when we're combating a slightly more aggressive prostate cancer, when we really need to escalate the intensity of therapy just a little bit. After you treat the prostate cancer, you still have to follow the patient. And that's probably the single most important part, because now they're treated, you have to monitor not just for cancer returning, but also for any side effects caused by the therapy itself. And so we follow patients typically based on PSA. So again, we're drawing that prostate-specific antigen, usually every 6 to 12 months. You consider an annual digital rectal exam, although that's probably not totally mandatory. And a lot of patients ask me about scans after their prostate cancer treatment. Well, do I need another MRI? Do I need another CT scan? The answer is no, you don't. Although prostate-specific antigen is a little bit controversial in the screening section, and we talked about that, it's actually extremely well validated and ultra sensitive and extraordinarily helpful in the surveillance setting after we've treated the prostate. Essentially what we see is we see that PSA plummet and go very low. With surgery, it goes all the way to 0. With radiation, it goes very low and kind of stays and hovers quite low. And as long as it doesn't consistently begin to rise, again in a concerning, consistent, alarming way, we're good, and that patient's cured of their prostate cancer. But what if it doesn't? What if it comes back? We cure most of the prostate cancer patients that we treat, overwhelmingly so the odds are definitely in that patient's favor, but sometimes treatment doesn't work, even if it was delivered with perfect intent and perfect delivery. But even if it comes back, there's still salvage options to get it the second time. So both of the treatments, surgery and radiation, can serve as backup for the others. There's also other options like cryotherapy or high-frequency ultrasound, targeted ablative therapies to treat the prostate in kind of a backup setting as well. So that's it for my talk today. I know we covered a lot of ground in a very short period of time. In case you want to do any more reading, here's some really high-quality resources online that I recommend that you go to. You can find a lot of different resources, including videos and interviews at these websites. And thank you very much for tuning in with us. I hope you got something from today's presentation. Thanks a lot.